Lateral epicondylitis, also known as tennis elbow, and lately proposed as lateral elbow tendinopathy, LET, is the most common overuse syndrome in the elbow. As the last description implies, it is a tendinopathy injury involving the extensor muscles of the forearm. These muscles originate on the lateral epicondylar region of the distal humerus. In many cases, the insertion of the extensor carpi radialis brevis is involved. It should be remembered that only 5% of people suffering from tennis elbow relate the injury to tennis. Contractile overloads that chronically stress the tendon near the attachment on the humerus are the primary cause of lateral elbow tendinopathy. It occurs often in repetitive upper extremity activities such as computer use, heavy lifting, forceful forearm pronation and supination, and repetitive vibration. Despite the name, you will also commonly see this chronic condition in other sports such as squash, badminton, baseball, swimming and field throwing events. People with repetitive one-sided movements in their jobs such as electricians, carpenters, gardeners, desk-bound jobs also commonly present with this condition. Clinically relevant anatomy. Lateral epicondylitis, also known as tennis elbow, and lately proposed as lateral elbow tendinopathy, is the most common overuse syndrome in the elbow. As the last description implies, it is a tendinopathy injury involving the extensor muscles of the forearm. These muscles originate on the lateral epicondylar region of the distal humerus. In many cases, the insertion of the extensor carpi radialis brevis is involved. Bony anatomy of the elbow. The elbow joint is made up of 3 bones: the humerus, upper arm bone, the radius and ulna, 2 bones in the forearm. At the distal end of the humerus there are 2 epicondyles, one lateral, on the outside, and one medial, on the inside. The area of maximal tenderness is usually an area just distal to the origin of the extensor muscles of the forearm at the lateral epicondyle. Most commonly, the extensor carpi radialis brevis is involved, but others may include the extensor digitorum, extensor carpi radialis longus, and extensor carpi ulnaris. The radial nerve is also in close proximity to this region, and divides into the superficial radial nerve and the posterior interosseous nerve. Epidemiology. Lateral elbow tendinopathy is classified as an overuse injury that may result in hyaline degeneration of the origin of the extensor tendon. Overuse of the muscles and tendons of the forearm and elbow together with repetitive contractions or manual tasks can put too much strain on the elbow tendons. These contractions or manual tasks require manipulation of the hand that causes maladaptations in tendon structure that lead to pain over the lateral epicondyle. Mostly, the pain is located anterior and distal from the lateral epicondyle. Elbow tendinopathy occurs at least 5 times more often and predominantly occurs on the lateral rather than on the medial aspect of the joint, with a 4:1 to 7:1 ratio. It affects 1 to 3% of the population, with those 35 to 50 years old most commonly being affected. If a patient is less than 35, it is important to consider differential diagnosis, growth plate disorder, referral from the cervical spine. If a patient is greater than 50, consider osteoarthritis, referred cervical spine pain. In a study by Nerschel, of 200 tennis players aged greater than 30, 50% had symptoms of lateral elbow tendinopathy at some stage. Lateral elbow tendinopathy is equally common in both sexes. Between the ages of 30 to 50 years the disease is most prevalent. Obtaining the condition at both lateral epicondyles is rare. The dominant arm has the greatest chance of the occurrence of lateral elbow tendinopathy. 20% of cases persist for more than a year. There are several opinions concerning the cause of lateral elbow tendinopathy. 1. Inflammation. Although the previous term epicondylitis implies the presence of an inflammatory condition, inflammation is present only in the earliest stages of the disease process. 2. Microscopic tearing. Nerschel and Patron attributed the cause to microscopic tearing with formation of reparative tissue, angiofibroblastic hyperplasia, in the origin of the extensor carpi radialis brevis muscle. This microtearing and repair response can lead to macroscopic tearing and structural failure of the origin of the extensor carpi radialis brevis muscle. 3. Degenerative process. The histopathological features of 11 patients who had lateral elbow tendinopathy were examined by Reagan et al. They determined that the cause of lateral elbow tendinopathy was more indicative of a degenerative process than an inflammatory process. The condition is degenerative with increased fibroblasts, vascular hyperplasia, proteoglycans and glycosaminoglycans, and disorganized and immature collagen. Repetitive eccentric or concentric overloading of the extensor muscle mass is thought to be the cause of this angiofibroblastic tendinosis of the extensor carpi radialis brevis. Lateral elbow tendinopathy is a degenerative condition in which increased fibroblastic activity and granulation tissue formation occur within the tendon. 4. Hypovascularity. Because this tendinous region contains areas that are relatively hypovascular, the tendinous unit is unable to respond adequately to repetitive forces transmitted through the muscle, resulting in declining functional tolerance. Clinical presentation. The most prominent symptom of lateral elbow tendinopathy is pain, which can be produced by palpation on the extensor muscle's origin on the lateral epicondyle. The pain can radiate upwards along the upper arm and downwards along the outside of the forearm and in rare cases even to the third and fourth fingers. There are 4 stages on the development of this injury with regard to the intensity of the symptoms. 1. Faint pain a couple of hours after the provoking activity. 2. Pain at the end of or immediately after the provoking activity. 3. Pain during the provoking activity, which intensifies after ceasing that activity. 4. Constant pain, which prohibits any activity. Furthermore, it is often seen that the flexibility and strength in the wrist extensor and posterior shoulder muscles are deficient. At least patients report weakness in their grip strength or difficulty carrying objects in their hand, especially with the elbow extended. This weakness is due to finger extensor and supinator weakness. Some people have a sense of paralysis, but this is rare. Symptoms last, on average, from 2 weeks to 2 years. 89% of the patients recover within 1 year without any treatment except perhaps avoidance of the painful movements, sport injuries.